Afternoon, everyone. Good morning, wherever you may be. And welcome to another session of our monthly cases. So today we have an exciting topic. But before we start, just a couple of announcements, just to let us have a smooth presentation. We will have a Q&A session at the end. So as the presenter makes his presentation, please type your questions in the Q&A panel at the bottom of your screen. So you'll be muted throughout, but if we're answering a question, you can raise your hand, and then you'll be unmuted to ask your question when you come to that time. So today's topic is the metabolic and biochemical effects of cancer. And to bring to us that topic in terms of review of cases is none other than Dr. Rav. Dr. Rav is not new to us. He has presented before during this series. So Dr. Rav is a consultant clinical biochemist at the Department of Clinical Biochemistry, Mid and South Essex, NHS. So he's done his studies in different countries, including Canada, as well as in the UK. And he holds a couple of teaching roles, and he's widely published. So his current research interests are in home self-testing, particularly with regards to monitoring prostate and colorectal cancer, the use of artificial intelligence in medicine, and the application of genomic medicine in clinical practice. He's also actively involved in e-learning, laboratory medicine, as well as the development of the same. So he is a member of the scientific committee of the Association for Laboratory Medicine in UK, and he is a reviewer for several leading scientific and medical journals, and previously was the deputy editor of the Annals of Clinical Biochemistry. So during his spare time, Dr. Sodi enjoys cycling and also enjoys playing the guitar. So you're most welcome, Dr. Rav. So with us today are young pathologists as well as residents in chemical pathology, as well as practicing senior pathologists. So over to you, Dr. Rav.
So thank you very much, Dr. Maina, for those very kind words. And welcome to all of you from wherever you are in Nigeria, in Ghana, in Kenya, and as well as in UK. So my name is Rav Sodi, and I have an interest in all things cancer, especially tumor markers. And being a clinical biochemist, I have an interest in monitoring blood results. I suspect this particular audience ranges from technicians all the way to chemical pathologists and professors. So whichever grade you are, you're most welcome to today's session. And today's session is quite broad. When I was asked to give this talk on the metabolic and biochemical effects of cancer, I had to make a decision either to focus on a particular case and go in depth, or try and cover all the important aspects. And I think I went for the latter. I think in this topic, breadth is more important than depth. And as you'll see today, there's many facets to cancer that we biochemists and chemical pathologists can help our fellow clinicians in helping patients. End of the day, we're all here to help the patient. So without further ado, I'll just launch my first slide. And just to say, during this session, we will have real cases, which I hope we've all seen in our clinical practice. But if not to worry, we'll talk about it today. Interspersed during this presentation will be little case, what I call case snippets very simple cases, but which illustrate very important principles. So as I said, today's plan really is to cover the breadth of the metabolic effects of cancer rather than go in depth in any one particular area. So intermittently, we will launch a poll of questions. Now, just to say, don't be shy to answer. You will not be down. There's no wrong or right answer. We're all here to learn and learn from each other. So we all know cancer is rising in sub-Saharan Africa. And this was a study published in the Lancet a few years ago by Professor Ngwa and his colleagues. And as you can see in the graph there, if you focus on Africa, about the year 2100, in probably not in everyone's lifetime, but maybe in our children's lifetime, cancer in Africa will have quadrupled. It's already at very high rates in Asia, and right across, maybe except Europe, cancer is on the rise. And we see this even in the UK. In many aspects of our practice, there's a feeling that cancer is rising. And the big challenge is how do we manage this, what one would rightly call a pandemic of sorts. So we know that the World Health Organization is looking into cancer, and they're trying to understand, A, what is the burden of cancer in the world? We know that 1 in 6 deaths in cancer in the world is due to cancer. At the moment, there's about 20 million people affected, and in the next 15 to 20 years, that will rise to 30 million. Now, thankfully, the WHO has got what's known as Sustainable Development Goals, SDGs. As you can see in this figure here, they are targets, and the aim is, roughly speaking, for both the lower income countries and high income countries, the idea is to try and bring the cancer burden to less than 5%. And if you look at the trajectory, it used to be that cancer was a condition in the higher income countries, but it recently, as of 2010, the low income countries have now surpassed the high income countries in the cancer burden. And this is the figure shown here is a probability of premature deaths from cancer. So the answer really is we need to invest and invest wisely. And there's a targets that the WHO have got, and there's a mission to try and save 7.3 million lives by the year 2030. So it's an ambitious goal, but I think we all have to get together and work to try and limit the burden of cancer. And I'm reminded of a quote by Malcolm X, who said, "Education is our passport to the future, but tomorrow belongs only to the people who prepare for it today." Knowing how to handle cancer means understanding the biology, the pathophysiology of cancer, and then working up better treatments. So I hope today's session will focus our minds, will empower us chemical pathologists and clinical biochemists and laboratory technicians to better help our physicians so they can better help patients. So let's take a step back and let's talk about carcinogenesis. How does cancer arise? Now, I'm showing you here, and I must say this at the outset, a very simplified view. I'm not an oncologist. I'm a clinical biochemist, a pathologist. And so I don't pretend to be an expert in all things cancer, but it is well appreciated that there are 3 steps to how cancer occurs, or what is the nature of malignancy. So the first step is initiation. There's DNA damage by carcinogens, by what we call mutagens. There's a role for free radicals and a role for proto-oncogenes, roughly speaking. These are genes that induce cancer. And once cancer is then initiated in a given cell, there's factors that promote cancer progression. And we see cell cycle disturbances. We see the role of what's known as tumor suppressor genes being inactivated. There's a role for apoptosis. So apoptosis can be defined as programmed cell death. So the cell has got a very unique evolutionarily conserved mechanism to kill cells that are not needed. And when this mechanism is disrupted, there's unproliferated cancer growth. And so cancer ensues. And of course, there's a role for oxidative stress. And once the promotion has ensued, you've got progression and metastasis. And there's roles here for angiogenesis. As the cells grow, they need a lot of blood supply. And so there's a lot of studies looking at how this process occurs and how the cell proliferates. So it's a very, very simplified view of initiation, promotion, and progression. But it should just lay the scene that cancer is a very complex condition. So to understand what cancer does to the body, we've got to understand the physical effects of tumor growth. As a tumor grows in size, it obviously will have physical effects. There's a space occupying effects. So for example, a classic example is prolactinoma. As a tumor grows in size, it will impinge upon the optical nerve, and this will affect the visual field. And we can test this clinically by visual field perimetry. And it's something we do routinely. Cancers also have obstructive effects. So a good example, again, would be a cancer of the head of the pancreas, which again will impinge upon the bile ducts and result in obstructive jaundice. Also, cancers can result in destruction of tissues. And another good example of that is pituitary tumors, which can either be primary or a secondary deposit from a breast or lung cancer, and this results in hypopituitarism. And we'll talk about this today in a case. And then we mustn't forget that cancer is actually stress on the system, and we've got what's known as a systemic inflammatory response syndrome, or what we better known as acute phase responses. So there's lots of changes to proteins, to signaling molecules in the body to try and combat these either infections or trauma or cancers. So there's a background of a systemic inflammatory response. We won't have time to go into that today, but please do look it up. It's very important to know this, especially in the setting of those in microbiology. It's very important in sepsis management. So here we go. So we'll start with the first case to lay the scene. So we're going to launch a poll shortly, but just before we do that, this was a 70-year-old woman who was told by her partner that she was starting to look rather yellow. So she went to a GP who requested some tests. So it's a very simple biochemistry there. You can look at the results. And the question then is, what is the liver function test pattern showing? A, is it predominantly hepatocellular pathology? Is it predominantly cholestatic? Is it mixed, or mainly is it bone? Launch poll now. So only answer case number one, the yellow woman, so that you've got answers there. So you can start answering now, A, B, or C, or D. And as I said, don't be shy. There's no wrong or right answer. We're all here to learn. So I'll give you about 30 seconds more to answer this question number one. Only question number one. Don't progress to question number two. So here is the answer then. So if you answered predominantly cholestatic picture, then you are correct. And the answer is quite obvious. If you look at the set of results in front of you, which I think we all do on a daily basis. So I've shown you the test, the result, and the reference range. The bilirubin is raised. The albumin is on the low side, as you'd expect in someone with cancer, as albumin is a negative acute phase reactant. But what's very much raised is the alkaline phosphatase. You know, it's almost 10 times the response. The gamma GT is also raised. The ALT and AST are also raised. It's very rare to have only the cholestatic markers being elevated. But here we would say there's predominantly a cholestatic picture. So this is a quick revision of liver function tests, and I'm sure we're all au fait with this. So just to move on then. So this person was then referred to the hospital where a cholangiography showed a dilated biliary system with narrowing bile ducts where it entered the duodenum. So you can look at this photograph here. The bile duct enters the duodenum around here, and you've got a pancreatic tumor that's impinging upon it. And because it's impinging upon the bile duct, if you can't pour bile into the duodenum, then it outpours into the blood and the person becomes jaundiced, and hence you turn yellow. And the best way of investigating for jaundice, as we all know, is looking at the sclera of the eyes. Depending on skin tone, it's not always easy to determine that. And the biochemistry, in this case, the raised bilirubin, supports jaundice. And jaundice is a very, very insidious symptom. Painless jaundice is very, very, must be properly investigated, because it can herald very serious cancers. And this is a good example, pancreatic cancer. And as we all know, pancreatic cancer is very hard to detect, and these patients normally show up when it's too late. So this case sets the scene just to show that how very simple biochemistry, things we look at every single day of our lives as biochemists and chemical pathologists, can actually help direct further investigations. This patient then had a laparotomy, and a carcinoma of the head of the pancreas was discovered. Regrettably, the patient died before we could intervene any further. Okay, then we should now move to the second question then. Now, this was a case, and this is a little bit more tricky depending on where you work in the world, because not all of us practice the same way. But it'd be nice to know at the end, when you do your post-session quiz, whether these cases are relevant to you or not. But anyway, we've got a 54-year-old postmenopausal woman complaining of being tired all the time. Now, tired all the time is something we see on the request forms all the time. It's very vague, but it can be quite a loaded statement sometimes. So in this situation, because the patient is tired, amongst other tests, the GP requested thyroid function tests. So now look at this thyroid function test here in front of you. You've got a TSH of 0.8 and a free T4 of 4.2. What would be your comment on the TSH concentration? Now, I don't know if the poll will work. I don't think it will. But maybe if someone can just shout out, or maybe in the question and answer, yeah, I think generally speaking, looking at the question and answer, there's a sense that people could not respond to the poll. I do apologize about that. But so maybe because the poll is not working, I will just answer the question here. Now, although the TSH is within the reference range, the free T4 is very low. And what you'd expected, so we would say the TSH is inappropriate for the given free T4. If you've got a free T4 of 4.2, there should be negative feedback to pituitary, and the pituitary should then, or rather lack of negative feedback to the pituitary, and the pituitary should respond by increasing TSH, right? But in this situation, the TSH is inappropriately normal, arguably low. So the correct answer would have been B, lower than expected. So let's talk about that a bit more. So in this case, as I said to you, the TSH is inappropriate for the low free T4. And that's because when the free T4 is high, it feeds back to the pituitary gland to switch off production of TSH. Conversely, when the free T4 is low, that stimulus is removed, and the pituitary gland should respond by increasing TSH, which it doesn't in this case. So immediately, this should tell you there is something else going on with the pituitary gland. And the big question then is this patient, by any chance, that this patient have hypopituitarism? And so, as chemical pathologists, now it depends where you are in the world, but in the UK, we've got the ability to add on other tests if we think it's necessary. Now, I appreciate in other countries where you pay for tests, this may not be easy. But even so, as a chemical pathologist, you can always alert the clinician to think about the results a bit further. Now, you look at this case here. So we added the LH, the FSH, the cortisol, and the prolactin. And as you can all see, the LH and FSH is very low. Now, don't forget, this is a postmenopausal woman. And a woman of 54 years of age who's postmenopausal, you would expect the normal LH and FSH to be much, much higher. So in my experience, I always think of it as it must be in the teens, at least more than 15. If it's not 15, then there's something else that's going on here. So Augustine's got a question. Can we bring this individual in, or should we wait to the end? Daniel, over to you.
Yes, I'm trying to figure out what the question is. I think we can proceed. I'll sort it out, Rav.
Okay. Well, don't worry. We'll come to your questions at the end. So I promise I'll answer your question at the end. So if we just proceed then here. So the LH and FSH is low for a postmenopausal woman. We then check cortisol. Now, normally I would ask my students, why would you do cortisol and not ACTH? Because we really want to do ACTH because that's what's secreted by the pituitary gland. Unfortunately, not all laboratories can do ACTH easily. There's a specialist test, and it's usually in the UK anyway. It's usually done by specialist laboratories, and we can send the sample there. But in clinical practice, you don't need to do that. The end product cortisol is a good surrogate. And as you can see there, for a morning sample, the cortisol was extremely low. We then added the prolactin, and lo and behold, the prolactin is extremely high, 3,700 for a postmenopausal woman. There's very few reasons why that should be the case. And no, she was not on any medications that would increase prolactin, classically antipsychotics. So she wasn't on that. So, and the other thing, just for your information, in my experience, and I think it's well known in the textbooks, the way the hormones go is the fertility hormones always go first. LH and FSH always go first, and then followed by cortisol and thyroxine. They tend to go later on. And the idea is the body will try and prioritize life over fertility. But that's just evolutionary speaking. So in this case here, as you can see, there's something else going on in this woman. And so we, just from a simple thyroid function test, we've uncovered a whole host of situation here. It's a whole new thing. So cortisol was low, and the results confirm panhypopituitarism. And so then the next thing is to do an MRI of the pituitary gland, and it revealed a macroadenoma, as you can see by the arrow pointing there. And so the other thing now going forward is very important. So these patients will then, once the tumor is resected or if they're treated, then you will need to monitor the patient's hormones. The key learning practice point is, so going forward, you need to monitor the thyroxine, not the TSH. I don't know how easy this is to do in your countries, because if you then give a clinician a TSH result, that might cause more confusion. So going forward as a practice point, you monitor the free T4 because you're replacing it. The TSH is never going to respond because obviously the patient after surgery will have no pituitary gland left. Okay, so it would be nice to have a question from someone about this, but we'll discuss at the end. Now, so this is a very busy slide, I do apologize, but on this slide, I've summarized all the biochemical changes observed in cancer. So as I said to you earlier, we're going for breadth rather than depth. And I don't want to read them out to you, but quickly just point some important points to you, excuse me. So in cancer, there's a lot of vomiting and diarrhea, either due to disease or due to treatment. So you do lose fluids, and this can result in hyponatremia. And there's many causes for the hyponatremia in cancer. It could be indeed due to fluid losses, so depletional hyponatremia. It could be due to water excess. Now, we'll talk about this. There's ectopic ADH secretion, or the better term is vasopressin, usually from lung tumors, and this can result in hyponatremia. Beware of pseudohyponatremia. Very important as chemical pathologists that we're aware of this, and we'll talk about this as well. Hyperkalemia could be associated with renal insufficiency in some cancers, for example, myeloma. But again, there are situations where you have to be very careful of pseudohyperkalemia. Important things for us as in our profession is to guide our clinicians to make the right decisions clinically and treatment, and also to have right treatment. So knowing the biochemistry, understanding the changes, whether they're real or not, is extremely important. There's always enzyme changes. Classically, there's a raised LDH. It's a marker of cell proliferation. But I have to say in my practice, we find this very non-specific, and apart from a few cases, not very helpful. So I would dissuade the necessary testing of LDH. ALK Phos, on the other hand, is very useful. It does show whether there's a secondaries or mets to the bone and liver. It's always useful to know this. We see this a lot in prostate cancer, when the cancer is then spread to the bone. and there's a raised alkaline phosphatase and normal gamma GT. It's a classical presentation. So alkaline phosphatase can be very useful. You do see raised amylases in ovarian carcinoma for various reasons. Don't forget, amylase is also produced by other organs, not just the salivary gland. There's, as you know from your biochemistry, there's the S and the P isoforms. That's a subject for a different talk. Protein deposition in the kidney can result in renal impairment. And the classic example is myeloma, which we'll also touch on today. There are other, not very often, but a bit more rarer biochemical presentations like lactic acidosis. And that's because malignant cells have a very high rate of glycolysis. And this has been put down to the overexpression of the enzyme hexokinase. Hypoglycemia is well documented in cancer, and this could be due to the overproduction of insulin growth factors, so IGF-2 especially by tumors. You've probably heard of the Doga-Porter syndrome. It's not very common, it's very rare, but something interesting to be aware of. And then hyperuricemia is a very, very, very common presentation in cancers. And this is mainly due to increased cell turnover and tumor destruction. And we'll touch on this today. Iron deficiency anemia almost seems to be universal in many cancers, especially colorectal cancers. And this is due to blood loss. And then there are specific organ involvement. We've talked about secondaries to the liver and bone. But they can also be primaries there as well. And you can see typical, very basic changes, like in the first case, you can see obstructive jaundice. And sometimes if it's a bone cancer, you will see a raised alk phos, but in that situation, the gamma GT is normal. So gamma GT, another very simple test we can request, can help tease out a lot of pathology. And then we also see exudation. Pleural effusions are very common in cancers. And we tend to measure all kinds of things in the fluids, proteins, LDH. There's something known as Light's criteria, which we use to try and decide whether an effusion is a transudate or an exudate, also very interesting. And then I mentioned the systemic inflammatory response syndrome. It's good to be aware of that. And then what's also interesting is you've got the re-expression of fetal isoforms, which have switched off with age, such as AFP. So AFP, alpha fetoprotein, is the main protein in the fetus. And as the child grows, then albumin takes over the role of AFP. But in cancers, especially germ cell tumors and liver cancers, AFP is then re-expressed. So these are all interesting points that we will see in practice. Good to be aware of them. You will have these slides as a reminder. But now let's focus on some of them in turn. So this is the third case then. So this is a case of hyponatremia, a very common presentation in our profession. Has many causes, is usually poorly understood, in my experience, very poorly managed as well. But here we've got a case of a 71-year-old man. He was admitted to the emergency department with severe back pain and weakness. So it must have been very severe for the UK emergency department to even see this person, because I don't know if you know the situation in the UK, the A&E is usually very inundated. But even so, here are the results then. It's a very busy slide, and I'll give you a few moments to just look at the information presented to you over 2 days in September this year and in August last year, and our reference ranges. So have a look, and the question posed here is, what is the likely cause of the hyponatremia in this case? Is it dilutional or hypovolemia? Is it depletional or is it true hypovolemia? Is it a pseudo hyponatremia? Or is it SIDH? There's no wrong or right answers. At this stage, if you want to pop a question in the question and answer, please do so, or raise your hands. So I'll give you about 15 seconds to just look at the results, and then we'll discuss it in depth. We already have some very quick answers. So there's some people who are really off the mark, really very quick. So that's quite impressive. Okay. If you're all happy, then we should proceed. Okay, so now in this case, first of all, I think you'll have all noticed that this is likely to be multiple myeloma. It's a very common presentation. And you might have all heard of the CRAB criteria, the CRAB, where the C stands for hypercalcemia. As you can see, the calcium is quite raised here. There's renal impairment. The creatinine is significantly increased from what it was the previous year. There's normocytic anemia, that's classical of myeloma, and there's some suggestion of bone involvement. Of course, you won't be able to tell at this stage until you do an X-ray, etc. But the back pain is a very common presentation of myeloma, and it can be missed. And again, the other big thing is the protein is very high. This protein of 110 should prompt us to do a protein electrophoresis, which we did in this case, and we did identify an IgG kappa, a very big one actually, and the patient was then referred to hematology. Now, that's hematology, but for chemical pathology, what's more interesting for us is, yes, we can diagnose multiple myeloma, our hematology colleagues will take over, but there's something else here that we should all look at. The question was, what is the cause of the low sodium in the situation? Is that sodium real? You know, and it can be easily missed. And I think looking at the question and answer session, a lot of people are saying pseudohyponatremia. So well done to all of you for spotting that. It is pseudohyponatremia. That's the basis of the low sodium. Now, there's two clues here. The obvious one is a very high total protein, but look at the osmolality. The osmolality is normal. A normal osmolality should suggest that this sodium is not correct. And it was quite similar to what it was last year, rather the year before, when the sodium was within the reference range. So you're absolutely correct. This is a pseudohyponatremia, and it's due to the so-called water exclusion effect. So what is that? Just as a reminder for all of us, forgive me if you know all of this, but just in case there's someone out there who's not very clear on what pseudohyponatremia is all about, let's talk about it now. So pseudohyponatremia, so basically, if you just take a step back, if you look at this figure here, normal plasma comprises about 93% water by volume. The remaining 7% is proteins and lipoproteins, which carry lipids. Now, we all use ion selective electrodes on our analyzers wherever we are in the world to measure sodium. I would doubt very much if we use any other method to do that. We used to use flame photometry in the past. You can use inductively coupled mass spectrometry, but that would be extremely expensive and not practical. We don't use absorption spectrometry anymore. I think in a modern laboratory, an ion selective electrode is commonly used, but there's a problem with using ion selective electrodes. So already, because just before I go any further, so because you've got a lot of lipids here, in a case where the protein or the lipid is very high, there's a water displacement. So look at this figure here. There's much smaller fraction of water. The fractional water content is much smaller, and it's mainly occupied by the protein or lipids. In this case, it's the proteins. So already you already have a lower sodium than you'd expect, because the analyzers only measure the water compartment. There's another issue with ISEs. The sample is diluted further, what we call indirect analysis. And the main reason for this is because you want to take a very small amount of the sample. And so there's a double whammy here, if you like. You've got a decrease in the fractional plasma water content, and you've got a dilution. Unfortunately, this will cause underestimation, because when you back calculate the true sodium, you underestimate, because the dilution is based on the total plasma volume, not just the water volume. So you base it on this, not on this. So you significantly underestimate. So in this situation, had you used a direct IC, which normally found on a blood gas analyzer, or you can, by the way, buy a direct IC analyzer, you'd have gotten an accurate result. And as I said, in this situation, the plasma osmolality will be normal, because that measures the number of particles in a kilo of water. Okay, so beware. This is you'll have these slides to study up, but the key message is here: beware when you see a high sodium, a low sodium, and you see a very high protein or a high lipid. Beware of pseudohyponatremia due to the water exclusion effect. Okay, so this is an important, if you like, finding for us chemical pathologists. Okay, so then moving on then, let's quickly check if there's any questions and answers. No, there's no questions so far. So in this situation, we've got a 60-year-old woman with chronic lymphocytic leukemia, another cancer. Now look at this table here. You can either pop your answers in the Q&A or put your hands up. What is the likely cause of the significantly raised potassium? So you can look at this. There's been a number of times this person has had potassiums done, but on the 20th of February, the potassium was 9.2 without any changes in the renal function. So this should already alert us there's something going on here that's not correct. And we then reanalyzed it on the same day, and that gave us a normal result. I'll tell you what we did on this time, but what are your thoughts at this stage? I'll give you about 15 seconds to gather your thoughts or answer the question in the Q&A functionality, and then we'll move forward.
Please type your answers in the Q&A. Yeah, I think there's an answer. There are two answers.
Yeah, there's two answers there.
Yep.
Yeah. Okay, well done, team. Very good. So yes, if you answered artifactual, that's the correct answer. Now, if I had the chance, I would ask you, what would you do in your laboratories to get a real answer? So let's just proceed to the next slide then. So in this situation, you can see the white cell count. You'd expect it to be very high in someone with chronic lymphocytic leukemia. And white cell counts or even high platelets tend to be fragile. That's loosely speaking. You probably had the fragile cell syndrome. And so when you centrifuge the sample using your normal procedures, you will rupture them. And as we all know, there's much higher levels of potassium within the cell than outside. All the potassium within the cell is then released into circulation, and hence the falsely raised potassium. And in clinical practice, clinicians will know this is not real, and they won't act on it. But there are subtle changes sometimes, and there's anecdotal evidence that clinicians, especially when they're very busy in the emergency department, have acted upon falsely raised potassium. So it's a very important clinical message here. Always question your results when you don't believe them. Always correlate results to the biochemical picture or to the clinical presentation. Yeah. So what we did was we asked for a repeat sample. So if you're using serum, what we find that works better is if you use plasma. So the lithium heparin plasma bottle, and the WHO color for that is a green bottle. That's the WHO standardized color bottles. But I realized different companies will have different bottle colors. So if you collect a plasma sample and then you handle it gently and bring it to the laboratory and you spin it at a slower rate than you normally would, you will get a normal result, or rather a more plausible result, because that's still potassium on the high side anyway. But this patient's always run a high potassium for various reasons anyway. And going forward, once we'd established that, our technicians were then aware, and whenever this patient sample came to the laboratory, it was analyzed using what we call the slow spin protocol. And I don't know how your IT systems work in your countries, but you can put flags on your results so that in future, when a chemical pathologist or clinical biochemist is reviewing the results, they will know that this is a patient with chronic lymphocytic cancer, and they will know maybe to undertake the slow spin protocol. So it depends how various countries function in terms of the local practice. And it'll be nice to have the discussion at the end. But suffice to say, in this situation, the high potassium was completely spurious and with a pseudo-hyperkalemia, and appropriate handling of the sample gave us a more plausible result. Okay, so moving on to another case then. So I'll just quickly look at the question and answer and see if there's any other things being, yeah. And then Simon Onsong was stated repeat sample collection. That's not a bad idea, but if you do so, then we must remember to handle it in the appropriate way. But yeah, absolutely, point taken. Okay, so moving on to the next case. So this is a woman presenting with sudden anuria. Okay, so that's reduced urine volume. A 61-year-old woman with blast cell leukemia. She was started on chemotherapy, and 3 days later, she was noted to have anuria. So you can see the results here. By the way, I've only been showing you selected results in the interest of time and space. So you've got results on the 10th of April, on 13th of April, and our given reference range. Now, based on this results shown and the information you've got there, what is the likely cause of this pattern of results. So look at the pattern of results. Ask yourself, first of all, um, what's normal, what's abnormal, and then try and see if you can work on a unified diagnosis. I'll give you about 15 seconds to do so. And whilst you're doing that, I've noticed some very good questions people have asked for. So Simon is asking, if you don't mind me answering, team, I'll just answer the question now. What centrifugation speed is recommended for a slow spin protocol and for how long? It's a very good question. So normally, I think in the UK, we verified that about 8 minutes at 3,500 revs per minute is what we normally use. But for slow spin, I would say half that. So 5 minutes for about 2,000 RPM. But whichever you decide, make sure you verify it locally. And that's a subject for another presentation. But I can always write to you later on, and I can always share our slow spin protocols. Unfortunately, there's no international agreement on these things because it depends on a number of factors. It depends on your centrifuge radius. It depends on your centrifuge model and make. But you can verify it locally and find something that works for all of you. Okay, so I think there's been a few answers posed. I should quickly have a look and see what the answers are. And I think we are pretty much, I think we pretty much have a consensus. Yeah, so the correct answer is tumor lysis syndrome. So moving on then. So let's talk about this. So in the setting of chemotherapy, the combination of, I don't know if you can see my mouse moving on the screen. I hope you can. But the combination of acute renal injury, you can see the potassium has suddenly, the urea and the creatinine have suddenly shot up over a very few days, a very short space of time. They've almost increased, by a factor of almost 9 and 4. And that's a really huge change. Something significant has happened. The potassium is also raised. There's metabolic acidosis there. The urate is almost 10 times what it was a few days earlier. The calcium is dropped and the phosphate is through the roof. So taken together, this pattern is classic of the tumor lysis syndrome. Now, as you all know, the tumor lysis syndrome is an oncological emergency and needs urgent treatment. Okay, and it's very common with lymphoproliferative malignancies, and is mainly in some patients and there are some risk factors which we'll talk about, and it's mainly due to chemotherapy or radiotherapy has started, or high dose steroids, or it can happen spontaneously. Now, if it happens spontaneously, it usually has very worse outcomes. And so let's talk about the pathophysiology of the tumor lysis syndrome. It's worth being aware of this when you're talking about cancer, because it's extremely serious. So I like to understand why things happen as they are. So if we go in turn for each of the electrolytes, so the potassium and the phosphate, it's simply because when the cell is lysed, the tumor cells is lysed, they're released into circulation. And other underlying factors can exacerbate them, such as renal insufficiency and acidosis, as in this case. And they have clinical consequences. As we all know, a high potassium will result in muscle and cardiac manifestations. Almost certainly the patient will need an ECG. You can have arrhythmias, seizures, and paresthesias. And phosphate can cause muscle and cardiac manifestations as well. Calcium is dropped, it's usually very low, and that's because of complexation with very high levels of phosphate released from cells. And this can also have cardiac manifestations and nephrocalcinosis. Urate, as we said, is a marker of cell turnover. So when you've got a lot of cells lysing and a lot of constant cell turnover, there's a huge load of purines being poured into circulation, which is then converted to the urea cycle into uric acid. Okay, and this can result in what's known as uric acid nephropathy. So good to be aware of that. There are risk factors that can exacerbate this, classically Walden depletion, which unfortunately is very common in cancer patients for various reasons. And of course, the reason for this is because the high uric acid, together with high phosphate, completely overwhelms the nephron's capacity to clear them. So you've got an outpouring into circulation. So taken together, this will result in tumor lysis syndrome. Now, there are some known risk factors. So if you've got pre-existing renal insufficiency, and that's already a risk factor. So in this situation, chemotherapy should be undertaken judiciously and carefully. The tumor mass itself, that could be a difficult one to gauge. But if you've got radiographic evidence of tumor mass, then you would know that's already a risk factor. It's been shown that if there's bone marrow involvement, then that's also another risk factor for this condition. And then, of course, measuring LDH, if there's more than 1500, that's a risk the cell is likely to lyse for various reasons which are not very clear. And then some tumors are quite sensitive. The one thing I've missed, it was not very common, is if you've got G6PD-DH deficiency, which is very common in some parts of the world, that's also another risk factor. Okay, so there we have it, tumor lysis syndrome. Beware of it if you're in the oncology setting. And of course, as chemical pathologists, as laboratory experts, we can help guide our clinicians appropriately. So very similar to the previous case, there's another case here for you, which is somewhat related. Actually, it's the same patient, a patient. So in the same patient, a day later, the lab technician called me and said the urate was completely undetectable. So the same patient again, on the 14th of April, you can see the results are much more improved because they probably instigated treatment on this patient, usually dialysis and other stabilizing treatments. But what's important for us to notice, look at the urate result. So it's completely unmeasurable. Now, here's a question for all of us. I'll give you about 20 seconds to answer this. This is an interesting one. What is a likely cause of the low urate concentration? So here I'm expecting a range of answers. So let's see how you answer. So go over to you, everyone. So what is the cause of the undetected or the vanishing urate? Is that result even plausible? So here I'm hoping an astute technician, if you're on the call, or one of our junior residents, would have spotted it and done something about it. So the answer, anyone wants to shout the answer out? No? Okay, so the answer is then, so one key principle, always exclude common causes first in laboratory medicine. If something is very simple, don't go looking for something complicated. It might be staring in the face. So if you had told me I would check for an aspiration error, I wouldn't have marked you wrong. I'd said, excellent, you've checked that. If you had told me you looked at the assay to make sure it's in date, it's been calibrated, there's no issue with it, you would not be wrong. If you had told me there was continued in vitro metabolism of the urate, you'd be spot on, because this is what happens in this setting. So these patients, because of the huge purine load, and if you can see in this figure here, purine is metabolized to uric acid via hypoxanthine and xanthine by xanthine oxidase, which incidentally is what allopurinol inhibits. But because of a huge load, it's a lot of risk of uric acid nephropathy. These patients are put on a drug called rasburicase. So rasburicase is recombinant urate oxidase, and it's been licensed for use to prevent tumor lysis syndrome. And what it does is it metabolizes the uric acid load to allantoin, which is then secreted by the urine, and it's used routinely in our hospital. Unfortunately, it's extremely potent that once in blood, it will continue to metabolize the urate in vitro. So when you collect your bloods, it will continue to metabolize it. There's no easy way around it. We've looked at ways of inhibiting it in vitro without success. But there's a very simple solution, actually, and it works very, very effectively. Now, you got to remember something. You want a correct urate result to know whether the rasburicase is working. So having a falsely low result doesn't really help you much, okay? And the result is falsely low because there's been continued metabolism in the blood bottles. Now, if you raise the sample to the lab quickly, you might not see this, but depending on your laboratory setting, where it is, and how the samples get to you from wherever they're taken, there can be quite a huge delay sometimes. And so there's continued metabolism of urate in the bottles. And a very simple solution is simply collect a sample on ice, chill the bottles and collect the samples on ice. If you know the patient is on raspberry case, you can plan ahead and have ice available. I don't know how easy that will be in your setting, but it's a very simple solution. This is a well-known phenomenon in literature, and there's a lot of practical help out there on how you can, erase things and how you can use ice slurry or ice bags to reduce the effect of raspberry case on uric acid. So I just thought it'd be good. It's a very simple case, but a very important learning and practice point, and not often appreciated. Okay, so there you have it. The vanishing urate in this case was due to raspberry case. Okay, so moving on then. So we've touched on the biochemistry of cancers, and I think it's important to also appreciate the endocrine manifestations of cancer. So this is an extremely interesting topic. It's quite huge, but cancers are known to secrete other products, which they shouldn't do, what we call ectopic. So I'm not a fan of the word ectopic because that implies that it shouldn't be there. And we all know that all cells are pluripotent, and they can, given the right circumstances, they can excrete things. So eutopic might be the correct terminology, but this terminology, ectopic, is now stuck in the literature. So I think we are beholden to use it, but just be aware of it. It's not ectopic necessarily, it's eutopic. But so anyway, cancers produce hormones and in very, very high levels. And this can mimic the actual disease condition. And we'll talk about this in turn. But there's some key factors about cancers. So if they do secrete hormones, they shouldn't, usually, but not always, they're non-suppressible. And I'll give you a few examples shortly. So we say they're autonomic. The production is also inefficient. So unfortunately, the syndromes only manifest when it's too late. It's in a very advanced state. And part of the reason for this is because the secretion of these hormones is usually incompletely processed hormones. The secretion, for example, instead of IGF-2, you'll have big IGF-2 being secreted. There is homology, but it's less efficient in its action, for example. Okay, so that, as I said, these tumors can also secrete hormones that mimic endocrine syndromes. And classically, hypercalcemia, we see hypercalcemia almost invariably in cancers, and we'll talk about it, but it's a manifestation of PTH-RP, not PTH. So we need to be very careful when we are labeling patients or trying to diagnose them. And then the important thing is those particular hormones will disappear, or they will reduce when the tumor is removed, and then reappear if the tumor recurs. Okay, so let's talk about this in turn then. So hypercalcemia is almost pathognomic in cancer, and there's many reasons why that happens. So you've got two ways of thinking about it. One is it could be humoral hypercalcemia of malignancy, i.e. the tumor is producing an agent that reaches the bone through the bloodstream. Classically, this is PTH-RP, and there's other cytokines that have been implicated. And these mimic the action of PTH, because that's what PTH does in the bone. And this is very common in squamous carcinoma. Also, you've got increased hydroxylation of 25-hydroxyvitamin D, which is the vitamin D we all measure, usually by lymphoma cells. And this produces 1,25-hydroxyvitamin D. And we all know from our biochemistry, this is the one that leads to increased intestinal reabsorption of calcium and phosphate, but not bone resorption. This is very analogous to sarcoidosis. So you've got humoral hypercalcemia malignancy, but then you also have local osteolytic hypercalcemia. And this is where the tumor metastasizes to the bone, and then it promotes bone resorption. And myeloma is a classic example of this. So there are two reasons why you've got high calcium in circulation. So here's a case for us to have a look at before we move on. So case 7, just to focus your mind. So you've got a 73-year-old man who's been admitted to the hospital in an acute confusional state. Now, he has a history of being a heavy smoker. On examination, he had finger clubbing and signs of a right-sided pleural effusion. Very important to note, he was euvolemic, clinically euvolemic. A chest radiograph confirmed the effusion and also showed, as you can see here, a mass on the right hilar region typical for carcinoma. So there's a cancer there. Okay, so here's a question for you, chemical pathologists and laboratory technicians. What is the likely cause of the hyponatremia in this case? Why is the sodium so low? Is it because there's depletion? Is it syndrome of inappropriate antidiuresis? Is it dilutional hyponatremia or the pseudohyponatremia? So I'll give you a few, about 30 seconds to collect your thoughts, and then we have a discussion. So Simon Onsongo is on the ball. I think he's quite quick off the mark. Thank you, Simon. So I think we may have given the answers away. I think others are answering similarly. So somebody has said C, and that's a quite interesting answer actually, because you're not actually wrong actually. Let's talk about that actually in the next slide. So I think I'll just quickly look at the question answers again to see if there's any other answers. So I think we've got a consensus that the answer is B, syndrome of inappropriate antidiuresis. And there's one answer with C, which is a really good discussion point. So if we just move to the next slide then. So yes, so first things first, the case synopsis. So this patient is clinically euvolemic. There's no signs of dehydration. I can tell you this out of the bat. Now, the normal response in this situation will be for vasopressin or ADH to be inhibited, resulting in the production of dilute urine. So the key thing here is you've got a low sodium and hyponatremia, and you've got what I call appropriate hyposmolality in plasma. So that's appropriate for the given sodium. So it's not a situation of a pseudo. But look at the urine. This is a situation where urine becomes extremely important. We don't always get urine in clinical practice. But if you see a result like this with the right history, always be certain to ask for a random urine sample, because that can open a whole can of worms, as it has in this case. So that's urine osmolality is completely inappropriate for the given sodium. You would expect if the sodium is low for the body to hold back as much sodium as possible. But it is in this situation, there is continued natriuresis, okay? And also, you'd expect the body to hold back, to secrete as much water as possible to correct the sodium. But in this situation, it's actually holding back, if anything. So the urine osmolality is consequently inappropriately high for the given serum sodium. So this is a case of syndrome of inappropriate antidiuresis. And if I move on then, let's just talk about it. And this at the outset, before I say anything else, you've probably seen the term syndrome of inappropriate antidiuretic hormone secretion. That's the term that seems to stick, but that's quite a misnomer. The more appropriate term is syndrome of inappropriate antidiuresis for two reasons. One, you don't always secrete ADH in this condition for various reasons, okay? And then secondly, because the correct terminology going forward is not ADH, it's actually vasopressin. So the syndrome of inappropriate antidiuresis is probably more accurate. And I think this is what the literature is now saying. We should move over to this. Now, this is a diagnosis that all junior clinicians like to make. All of us like to make diagnosis, but there's very clear laboratory criteria. But one thing I will say at the outset, if you're going to make this diagnosis, you want to do so before you start fluid resuscitation, because otherwise it becomes very complicated to interpret the blood results. And classically, what you see is hyponatremia. The sodium is usually less than 125. There's hypoosmolality. There's an appropriately low serum osmolality. However, the clincher is the inappropriately concentrated urine. What we not like to say is not maximally dilute. So anything more than 100 will be deemed, in this setting, will be deemed inappropriate. And this continued natriuresis, you'd expect the body to hold back on the sodium. In this situation, the sodium continues to be excreted. Usually we say more than 30, but in the literature, it goes as low as 20. In any case, that would be inappropriate anyway. The other clincher is euvolemia. Now, you might be wondering, so what? Why is SIDH important? It is very important to distinguish it and diagnose it because the treatment is very, very different. In the case of SIDH, the treatment is fluid restriction, whereas in other situations, depletional hyponatremia or cerebral salt wasting, the treatment is repletion. So it's very important to make that distinction. It's not just academic, it's important in clinical practice. But to make the diagnosis, you've got to ascertain that there is normal renal, adrenal, thyroid, cardiac function. And the patient is not on drugs that will affect fluid excretion, or the excretion of sodium as well. So it is a diagnosis of exclusion, but usually it's pretty clinically quite obvious. The main causes are ectopic secretion, like in this case, we saw a bronchial carcinoma on the lung, or inappropriate secretion. And this is very common in lung or in brain conditions. Usually in any lung or brain conditions, you will see inappropriate secretion, ectopic secretion of vasopressin. Okay, so there we have it, syndrome of inappropriate antidiuresis. Okay, there are other hormones that can be secreted ectopically, and one of them is ACTH, and it can present as Cushing's. So this is the uncontrolled secretion of ACTH by tumors. Classically, there's a small cell carcinoma of the lung, and pheochromocytoma can do the same. The thing about this is that it's so rapid that patients may not show the typical Cushing syndrome features. And we can use biochemical tests to distinguish Cushing syndromes due to ectopic or pituitary or adrenal tumors. This is a very interesting topic, but unfortunately, it's beyond the scope of today's lecture. But yeah, so there you go. You have beware of ectopic secretion of ACTH. Now, here's an interesting case for you to consider. So a 38-year-old man presented with a racing heart and a rapid pulse, and he came to the emergency department. Now, because of the racing heart and rapid pulse, amongst other tests, a thyroid function test was requested. And it showed hypothyroidism, as you can see here. So carbimazole, which is an antithyroidal, was started. But on examination, a swelling was found on the neck. And this prompted a fine needle aspiration, which showed a poorly differentiated tumor, and which was then confirmed by an open biopsy, and chemotherapy was commenced. Now, the staining showed a very high beta-HCG, and this was also measured, as you can see here. It was initially in the millions. So we went back and we measured the HCG, and as you can see here, the HCG and the TSH almost mirror each other. Okay. We also, I might give it away now, but we also measured this man's estradiol, and for a man, it was very high, 2,730. And AFP and CEA were normal. On chest X-ray, we found multiple secondaries in the lung. And this to say, we diagnosed a germ cell tumor in this individual, hence the high HCG. Now, if you look at the TSH and the HCG, they seem to mirror each other. Whenever the HCG is very high, the TSH is completely suppressed. And as the HCG comes down, and the TSH then starts to normalize. And likewise with the free T4. So I'll give you your thoughts now. So there's no multiple choice question for this. But if anybody wants to shout out the diagnosis, do so now in the question and answers. I'll give you about 15 seconds to do so. So this is not a very common picture, but in situations where you do come across a germ cell tumor, you might see this. Okay, so I think the answer has been given away. So we'll move on to the next. Yeah. So just to mention then, HCG is a small peptide produced by the trophoblast cells of the placenta and also by the anterior pituitary in small concentrations, especially we see this in postmenopausal women. And many tumors produce HCG, as germ cell tumors, some liver tumor, some other cancers produce HCG, but they only serve as a tumor marker. There's no obvious clinical manifestation. However, in trophoblastic proliferations, such as cholangiocarcinoma, the secretions can be very, very, very high, and this can have an unexpected clinical consequence. And why is this? So let's just take a step back. And this is because all glycoprotein hormones, LH, FSH, TSH, and HCG, they all share structural homology. They all have a common alpha subunit with a unique beta subunit. Now, at very high HCG concentrations, as someone has pointed out in the question and answer facility, there may be TSF receptor stimulation, resulting in increased thyroxine secretion. And this will then feed back and switch off TSH. So you've got hypothyroidism. So this is a situation of ACG-induced thyrotoxicosis. And we do see this in clinical practice, and it does cause a lot of confusion. What I didn't tell you was because the stimulation of the LH receptors, this can lead to gynecomastia in men. And as you can see in this particular case, the estradiol was very high as well. So this is a very rare manifestation, and I think it's just worthwhile knowing that hormones can act strangely for various reasons in cancer. Okay. So then I think it could be remiss not to mention paraneoplastic syndromes in the setting of a lecture such as this. So what is a paraneoplastic syndrome? So one definition I like is it's a systemic manifestation of cancer not directly related to the physical presence of the tumor per se, but is usually due to an altered immunogenic response. And this could be due to the cancers producing autoantibodies, cytokines, hormones, etc. And they affect multiple organs in the system. So this is beyond today's presentation, but I think if you get a chance, look them up. They're very interesting, and they can cause diagnostic conundrums for us. So it's very important to be aware of paraneoplastic syndromes. This is a summary of all the consequences of malignancies of endocrine glands. So in the anterior pituitary, the secretion of growth hormone, or rather should I say the excess secretion of growth hormone, can result in acromegaly. We've talked about the raised ACTH causing a Cushing syndrome-like picture. Prolactin itself can result in infertility, galactorrhea, and amenorrhea. TSH, as we saw in the last case, can result in thyrotoxicosis. If the cancer is in the thyroid and a lot of thyroxine is produced, then you can have thyrotoxicosis. Calcitonin in medullary thyroid carcinoma, there's no known consequence. In the chief cell parathyroid gland, the increased secretion of PTH can result in primary hyperparathyroidism. In the adrenal gland, increased secretions of steroids and catecholamines can result in Cushing syndromes or pheochromocytoma, which is a well-known tumor. In the ovary, the excess secretions of estrogens and androgens can result in a number of manifestations, including virilization, if you've got raised testosterone in women. So there's a summary of this. You'll have these slides to study up, so don't worry about taking extensive notes. And then just in closing, just to mention, neuroendocrine tumors are another very interesting facet of cancers. So neuroendocrine tumors are tumors that occur outside the endocrine glands, but they arise from neuroendocrine cells, which are widely distributed throughout the body. There's something common about them, and that is that they all secrete biogenic amines. And that's why they were previously known as APUD tumors, which is amine precursor uptake and decarboxylation tumors. That's a bit of a mouthful, so I rather prefer neuroendocrine tumors, and I'm sure you do too. They're very common in intestines, such as carcinoid tumors, or in the lung, such as small cell carcinoma. Also, it's important to realize cancers can be familial. And if it's autosomal dominant, as we all know, the first degree relatives can be 50% effect rate. Thankfully, it's rare. But one thing we all should be aware of in our field is men, multiple endocrine neoplasia. This is an autosomal dominant condition in which tumors or hyperplasia develop in 2 or more endocrine glands. And I've summarized them for you in this table here. Classically, you've got MEN1, which is also known as the Wermer syndrome, or MEN2, which is known as the Sippel syndrome. And the way they present is MEN1, half of them have got a pituitary adenoma, nearly all of them have got a parathyroid involvement, and then half of them have got a pancreatic involvement. And usually that's a gastrinoma, which can cause the so-called Zollinger-Ellison syndrome, which is classically presents with peptic ulcer disease. MEN2A, nearly all of them, in fact, all of them have got medullary carcinoma of the thyroid, and then half have got pheochromocytoma, and a third have got parathyroid involvement. MEN2B is a variant, where again, all of them have got medullary thyroid carcinoma, and half have got pheochromocytoma, but they also have a ganglioneuroma, amongst other abnormalities, such as amarphanoid habitus. That's a summary of MEM there for you. And unfortunately, given the time, I could not cover other topics which I think are important and related, such as the carcinoid syndrome, pheochromocytoma, And then the other one I have a huge interest in, I've published about it, is tumor-induced osteomalacia. This results in hypophosphatemia. It's notoriously difficult to diagnose, but there's new roles for FGF23 testing. You must have all heard of FGF23, if not, worth looking up. And I've not covered tumor markers in this session. This was done by myself in the previous lecture, which is available online. So thank you so much for your attention. I know it was a whiz through the endocrine and biochemical effects of cancer. As I said, a huge, broad topic, but I hope the cases have homed in on some key points, which chemical pathologists and us biochemists will see in our daily practice, and we can help our colleagues.